There's also arteries inside of the chest wall that they can redirect onto the heart instead of going to the muscles of the chest wall, which can also be used for bypass. So that's how they do it. But it just takes a lot longer. Go ahead.
How hard is it to do a bypass when the heart is like pumping, moving?
That's a great question. It's actually very hard to do. So in order to do bypass, you have to stop the heart and put the patient on a heart-lung machine, which is basically a pump that drives the blood through the circulation while the heart is stopped. So you have to actually redirect the blood out of the body through a machine and back into the body. So that's a big deal. Question?
If that way the bypass takes so much time, and like the better way is just to put a catheter in, then why would they ever do the bypass?
That's a great question. So for patients who are having a heart attack, really, we don't do bypass ever anymore because it just takes too long. For patients who have multiple blockages but who have stable symptoms, in other words, if they walk around, they get chest pains, but if they're sitting, they're fine. Those patients, it depends on how many blockages they have. If they have too many blockages, it's often safer to do bypass surgery. But that's in a controlled situation. It's not an emergency. So pretty much in 2011, anybody who's having a heart attack, it's the 1 in a million patient who needs an emergency bypass surgery. Yeah.
Yes, you said that you can feel the pain in your jaw or back or somewhere. So do that determine the location of the blood artery?
Not necessarily. Not necessarily. They don't necessarily correlate directly. Yeah.
So can somebody have a heart attack without having a clogged artery? Or a blocked artery?
There are very rare situations where people who are born with abnormalities of the heart arteries can have, heart attacks without a conventional blockage. You can also have a blood clot that's somewhere else fly into the artery and block the artery. It's not a heart attack in the conventional sense, but that's a very small fraction, less than 1% of all heart attacks. The overwhelming majority of patients have this. Right? Okay, so let's talk about some of the state-of-the-art technology so we can quickly move through this. Heart catheterization was actually started in 1844. It's been around for a long time. Claude Bernard was trying to measure blood pressure, and he actually put using animal models, which is how they used to do this, they put a catheter through the artery in the neck of a horse to measure the blood pressure and the temperature. It wasn't until the 1920s that people said, hey, this might be something we can do for people to make diagnosis and potential therapy. And this Dr. Forsman, who was a German urologist actually, wanted to do this on people, but nobody would volunteer, as you might imagine. So he did it on himself. This is Dr. Forsman. What he did was he cut down to a vein in his forearm, put a catheter in, and this is the catheter, this line here, and he put it all the way up into his heart.
By himself?
By himself. And then he walked 2 flights of stairs to go to the x-ray, where he got this picture, because nobody would believe him unless he had proof. So he walked upstairs, got the x-ray, and had proof that you could put a heart catheter in a living patient, and the patient wouldn't die.
Why didn't you do it in the same?
Yeah, why didn't you just do it?
Yeah, well, that would have been a smart thing, but he probably didn't think that far ahead.
You just do it in the.
He didn't have any heart problems. He was just trying to demonstrate that the technique would work. So he got in trouble for doing this, as you might imagine. But a few years later, after others had worked on this, he won the Nobel Prize. Because this finding, this technique, is such an important technique in the treatment of patients, millions of patients worldwide, that it was a worthy discovery, and he won the Nobel Prize. So just because people called him crazy doesn't mean he was totally crazy. In 1958, here at the Cleveland Clinic, Mason Sons was actually one of the godfathers of our field, and he was actually one of the guys who discovered that you could selectively engage the heart arteries, the coronaries, and take angiograms, like I showed you earlier. So the first coronary angiogram was done a few blocks from here. It was done by accident, because the catheter, which was supposed to be in the aorta, slipped into one of the coronary arteries, and they injected the dye, and they had a beautiful tracing of the entire coronary, and the patient survived. And they recognized that it could be done safely if they didn't inject too much dye. So you're in the shadow of greatness here with in this field. Yeah.
when they shoot the dye, they put them on an X-ray machine.
Correct.
Then what is the dye? Does it have like?
The dye is very dense. It's got iodine in it, and that, like bone, doesn't let the X-rays penetrate. So just like when you break a leg and you get an X-ray, the dye, because it's so dense, is visualized by the X-ray. Okay. And then the first angioplasty was done in 1977 in Switzerland by a guy named Grunzig. That is sort of the basic history of angioplasty. So you were asking earlier, how do we get that tube into the leg? The way we do it is we take a small needle, we put it into the artery, and then we pass a wire, and then everything is done over the wire. So basically, it's like if you've ever had a blocked pipe in your house, you put a plumber's snake down, and that snake is like a wire that will allow you to transition all of your different catheters in and out of the body. Okay, so there's always a catheter with a wire in the artery. Does that make sense? Basically, you have a wire like this, okay, and then all of the catheters will get threaded in and out of the body over this wire. So these wires are pretty long. So if I keep pushing this wire, it'll come out the back end of it. So in order to have access to the body's arteries, you need to have a wire that comes through and through. It's all right. This seems better than this. Okay? So I'm going to pass this around for you guys to see. Right, this is the catheter with the wires. And this is the balloon catheter. You can see how small these devices really are. Sorry, here we go. Yep. So these are the catheters that come in all different shapes and sizes. The first use of angioplasty actually was in the leg artery of a patient in 1964. And then Grunzig, as we described, did the first human angioplasty. He built this catheter in his garage because there were no companies building catheters. So he basically experimented for years and years working on these catheters, and then finally was able to build one, sterilize it, and use it in a real patient. And this is actually a picture of the first angioplasty. You can see up here, there's a narrowing in this artery. See how it looks like it's pinched? This is after the angioplasty, which is actually quite a beautiful result. And this is 10 years later. It still looks like that, which is lucky, actually. And we'll talk about why. So what happens when you do an angioplasty? Basically, when you take the balloon and you inflate it inside the artery, you're kind of ripping to shreds the inside of the artery. So somebody asked earlier, what happens if you tear the artery? The truth is, every time you do an angioplasty, you're tearing the artery. But what you're trying to do is do it in a controlled way so that the artery is not inflated too big so that it doesn't rupture. And the way we figure that out is by starting with smaller balloons and then working up with larger balloons. So we never go in with like a really huge balloon first. We go in with smaller balloons and we gradually build them up so that the artery stretches progressively over time. That's how we avoid tearing the artery open. But that's essentially what happens. And when people first started doing this, nobody believed that this would work. You know, they said, well, if you're going to tear the artery, how good of a therapy could that really be? But in the last 30 years, it's become the standard of care around the world because it really works. And so this is sort of some of the technologies that have evolved over the last 30 years. Started out with angioplasty, then we had all kinds of devices to actually cut out the atherosclerosis from inside the artery called atherectomy. Then we developed stents, and you've talked about it a little bit. We'll talk about it some more in detail today. And then we've had new drugs or pharmacology to help treat these blockages in addition to the stents. And then we've had other kinds of treatments with drug-coated stents, which we'll talk about today. And now in 2011, we have stem cell technologies. We have stents that dissolve over time so that they're not there permanently and things like that. Any question?
For the stents and the capital wires, do you like tailor the size of the wire by the height of the person?
They're actually all extra long, so that all of the wires are plenty long enough. And you don't mind if it's too long, you do mind if it's too short. So one of these techniques is called atherectomy. So in addition to balloon, which is the first step therapy, we have these techniques. This is a diamond tip drill, which spins at 150,000 RPM. So if you ever go to the dentist and have the unfortunate experience of having a tooth drilled, that's what this thing sounds like. Okay? And it actually can drill through the calcium and the cholesterol narrowings and open the artery. Obviously, the risk is that you can tear the artery, so you need to know what you're doing when you do this. But this is one of the advanced techniques that we have available to open arteries that are blocked. We also have balloons that have blades on them, called cutting balloons, which so when you open the balloon, the blades will actually make incisions in the artery that help release the blockage. And so if you have a really tight narrowing that won't open up with balloons, we can use these kinds of devices to help open the artery from within. Yeah.
With the drill, does anyone ever get freaked out by the sound of it?
We give them a lot of sedation so they can't really hear it, usually. We make them pretty sleepy. Yeah.
If you're cutting up an artery with a balloon, won't it just cause more place for plaque to collect?
Well, it turns out that usually after you cut the artery with the balloon, you put a stent in and keep it open. So it's not like you're making new areas where cholesterol plaque can lie. We also can use lasers in a similar technique. The lasers, as shown up here in the upper right, can direct heat sources to the site of the plaque and actually melt the plaque away. The bottom line is that all of these techniques are used infrequently, and the mainstay of treatment is with stents. Okay, and stents are like the picture on the top. This is the very first stent that was used in human clinical use for coronary artery disease. That was released in 1992 here in the United States. And that stent is basically a scaffolding. It's like a wire mesh that when you inflate the balloon, opens the artery and holds it open. The reason that's important is that when you use a balloon, once the balloon is deflated, the artery can re-narrow because it's elastic. It's got properties of the skin. It will recoil back to the original position. If you pull up on your skin, once you let go, it'll go back to its original location. Same thing happens inside the arteries. So if you want to keep it open, you need to put in some kind of support, and that's what a stent does. They are mounted on the same kinds of balloons that you're passing around, and then they're deployed the same way. Basically, we go in over the wire through catheters, up into the artery of the heart. We find the location we need to fix it. I'll show you a picture of that in a second. Once the stent gets put in, it's permanent. It's there forever. It gets embedded into the artery wall, and I'll show you a picture of that too in a second. 1992 was the first approval. They became widely available in 1994. And now, every year, there's about 2 to 3 million procedures with stents in the world. And now with the availability of stents being greater in other parts of the world, South America, Africa, Asia, we'll probably see even more procedures done than ever before. And it's a standard therapy for treating a heart attack. And we like to do it within 90 minutes of the onset of symptoms. In other words, the faster you do it, the less heart muscle is damaged. So let's go back to our patient. Okay. So what we do first is, if you can see here in this panel, this is our catheter. This is the wire that's all the way across the blockage. And this little dot that's moving up and down is a special suction catheter that allows us to suck the clot out of the artery. And this is what the artery looks like after we suck the clot out. You can see right here, there's a severe narrowing right there. See that?
Yeah.
Looks like there's a pinch. That's a cholesterol plaque that's ruptured. Okay? So then what we do is we take a balloon, like we have passed around with you guys. We blow up that balloon. And then we put in a stent, which goes in basically the same way. And this all happens over the course of about a minute. And that's what the final picture looks like. Okay, can you see that? See this? That's where the narrowing used to be. And now it's basically gone. You can't tell where the narrowing was. And there's a stent holding that artery over there. Yeah.
So behind the pinch, like the blood will just sit there, or will it flow? Or?
It's flowing. So imagine like you have a pipe that's narrowed. So if you have a pipe that's this big and then it narrows down to this, the blood's going to still flow through it. It's going to have a harder time to get across the blockage, right? So now you take that blockage and you blow it up so it's the same size as the rest of the artery. Yeah.
Is the reason at the beginning of this balloon is like a catheter, so it won't hurt the person?
Yeah, so that it's actually blunt on the end of it, so it can't, pierce through the artery